Good afternoon, everyone. I am Joanne Starks of SEDL, or CEDL, in Austin, Texas, and I'll be moderating today's webcast on evidence-informed policymaking, a CIHR knowledge translation approach. The webcast is offered through the Center on Knowledge Translation for Disability and Rehabilitation Research, or KTDRR, which is funded by the National Institute on Disability and Rehabilitation Research, or NIDR, in the U.S. Department of Education. I want to thank my colleague Ann Williams for logistical and technical support for today's webcast. A reminder that we will ask you to complete a brief evaluation at the end of today's webcast. I'll give more instructions following the presentation. And since the slides are small on the screen, it might be helpful to download a copy of the presentation file from the KTDRR's website at www.ktdrr.org. The Center on KTDRR is working with a number of national and international partners, and one of those is the Canadian Institutes of Health Research, or CIHR. You are probably aware of the fact that CIHR, which is the Government of Canada's Health Research Investment Agency, was the first to define and embrace the term knowledge translation, or KT. We are partnering with CIHR's Knowledge Translation Strategy Unit to learn about the innovative KT strategies they are continuing to develop and implement. This webcast on evidence-informed policymaking is part of a series of 4 webcasts that also include KT 101, Knowledge Translation Initiatives at CIHR, Ethics in Research, a Science Lifecycle Approach, and Citizen and Patient Engagement. Today's webcast will share information on 2 evidence-informed policymaking initiatives at CIHR, the Evidence-Informed Healthcare Renewal Signature Initiative and the Drug Safety and Effectiveness Network. We will also learn about several KT programs, the Best Brains Exchanges, Partnerships for Health System Improvement, Knowledge Synthesis, Knowledge to Action, and Science Policy Fellowships. Presenters will describe some of the lessons learned in developing and delivering these programs, and finally, participants from these initiatives will offer tips on moving science into policy. Our speakers today are Megan Baker, Jennifer Campbell, and Diane Forbes from CIHR, Michael Wilson from McMaster University, and Daniel McLean from Health Canada. Megan Baker, MSc, is Senior Knowledge Translation Specialist at the Canadian Institutes of Health Research. She has organized today's webcast, and I'll ask her to introduce the other speakers that will be joining her. I want to welcome all of our speakers. We are really looking forward to what you have to share with us today. Megan, are you ready to begin?
I am. Thank you, Joanne. So on today's webcast, I'm going to begin with a brief overview of what the Canadian Institutes of Health Research, what the organization is, who we are, and what we do, as well as outline how we are committed to evidence-informed policymaking through our knowledge translation approaches and programs. I will follow that with an overview of what evidence-informed policymaking is, outline some knowledge approaches, and what are knowledge users and why use them. This will be followed by presentations that outline some evidence-informed policymaking programs and initiatives at CIHR, including the Evidence-Informed Healthcare Renewal Signature Initiative and the Drug Safety and Effectiveness Network. This will also be followed by a few knowledge translation programs. I will outline the Best Brains Exchange Program, Partnerships for Health System Improvement Program, the Knowledge Synthesis Program, Knowledge to Action Program, and last but not least, the Science Policy Fellowship. We will wrap up the webcast with a look at so what is next, and what have you learned from the presentation. On today's webcast, we have 4 presenters. We have Jennifer Campbell, who is a Senior Advisor from the Evidence-Informed Healthcare Renewal Signature Initiative here at CIHR. We have Diane Forbes, who is an Associate Director from the Drug Safety and Effectiveness Network at CIHR. Michael Wilson, Assistant Director from the McMaster Health Forum and Assistant Professor from the Department of Clinical Epidemiology and Biostatistics at McMaster University, and Daniel McLean, who is a Policy Analyst within the Health Products and Food Branch Inspectorate at Health Canada. So first we'll begin with a look at what CIHR is and what we do. As Joanne mentioned, CIHR is the Government of Canada's Health Research Investment Agency. Our mission is to create new scientific knowledge and to enable its translation into health, more effective health services and products, and a strengthened healthcare system. We support more than 14,000 researchers and trainees, primarily through granting mechanisms and not contracts. At CIHR, we take a solutions-based and multidisciplinary approach to our health challenges that are facing Canadians today. And we are committed to facilitating the move of research results into action and working collaboratively with partners. CIHR is made up of 13 virtual institutes that are housed at universities across Canada, where a scientific director leads each one. At Ottawa, at the headquarters, there is a staff that supports these institutes. Each institute has an institute advisory board that links them to their respective community of researchers, knowledge users, and policymakers. On this slide, you will see CIHR's definition of knowledge translation. At CIHR, knowledge translation, or KT, is about making knowledge users aware of new knowledge and actively facilitating the use of knowledge to improve health, health services, and health systems through evidence-based and also practice-based results. It's about closing the gap between what we know and what we do, reducing that know-do. And thirdly, it's moving towards research, or moving research knowledge into concrete action. If we were to further deconstruct the KT definition from the previous slide, we would see that it is made up of the following components. Knowledge synthesis, which is the contextualization and integration of research findings of individual research studies into the larger body of knowledge on the topic. It also includes dissemination, which involves identifying the appropriate audience for the research findings and tailoring the message and media to the audience. It also includes knowledge exchange, which refers to the interaction between the knowledge user and the researcher, resulting in mutual learning, and encompasses the concept of collaborative and participatory action-oriented research, where researchers work together as partners to conduct research to solve the knowledge user's problems. That's also IKT, or integrated KT. And finally, the definition also includes the ethically sound application. This is the iterative process by which knowledge is actually considered, put into practice, or used to improve health in the health system. It is here that KT activities must be consistent with ethical principles and norms, social values, as well as legal and other regulatory frameworks. Ultimately, knowledge translation is the bridge between discovery and impact. It is the bridge between researchers and knowledge users. So next, we'll look at a few knowledge translation approaches and what and who knowledge users are. So we'll look at what is evidence-informed policymaking. John Levis and his colleagues from McMaster University have defined evidence-informed policymaking, an approach to policy decisions that aims to ensure that decision-making is well informed by the best available research evidence. It is characterized by the systematic and transparent access to and appraisal of evidence as an input into policymaking process. At CIHR, there are two key KT approaches that we encourage researchers and policymakers alike to use and consider to increase and facilitate evidence-informed policymaking and increase the impact and uptake of research outcomes. These are end-of-grant KT and integrated KT. An end-of-grant KT plan and approach ensures that findings of a research study will be made available and accessible to appropriate audiences and stakeholders, while funding IKT projects increases the likelihood that results will be relevant to end users, which in turn increases the likelihood of uptake of research findings. Over the next few slides, I will provide more detail. So end-of-grant KT can include the following components. Diffusion, and this is the let it happen method. This involves the communication of information using delivery mechanisms for which little customization is required to reach target audiences that typically seek out the research evidence. The second is dissemination, which is the let it happen method. It is more tailored in that it is a communication vehicle that messages are adapted to the specific audience and or context in which the knowledge will be used. it is important to consider both the process for adapting the evidence and the strategies for dissemination. And finally, the application or make it happen method that is more tailored still as it moves knowledge into use in cases where strength of the evidence is sufficient. Selected strategies should be well justified in the context of the goals and target audiences and should consider barriers and facilitators to knowledge use. On the other hand, integrated KT is an approach of doing research that applies the principles of knowledge translation through the entire research process. The central premise of IKT is that involving knowledge users as equal partners alongside researchers will lead to research that is more relevant to and more likely to be useful to the knowledge users. Each stage in the research process is an opportunity for significant collaboration with knowledge users, including the development of or refinement of the research questions, the selection of the methodology, data collection and development tools, selection of outcome measures, interpretation of findings, crafting the message, and dissemination of the results. It should be noted that IKT programs also require a dissemination plan, and that's end of grant KT. So those submitting or reviewing IKT proposals on research grants will consult with both sections of this guide that you will find online once I show the reference section. Now let's take a step back. What are knowledge users? A knowledge user is an individual who is likely to be able to use the knowledge generated through research in order to make informed decisions about health policies, programs, or practices, and whose level of engagement in the research process may vary in intensity and complexity depending on the nature of the research and their information needs. Some examples of a knowledge user can be a practitioner, a policymaker, educator, decision maker, healthcare administrator, community leader, or an individual in a health charity, patient group, or private sector organization. Now, why are knowledge users important? And you may ask. Well, there's an extensive amount of academic literature which describes how the involvement of knowledge users in the research process, will increase the likelihood and uptake of research results and improve the relevance of the research findings. Through partnerships, the research is strengthened. Research can be more solutions-based because there's a knowledge user involved in developing the research question, and research can have more of an impact because the end user is engaged and interested, ready for results, and willing to move those results into practice because they are a direct relevance to the day-to-day lives. It is at this time I'd like to introduce Jennifer Campbell to provide an overview of the evidence-informed healthcare renewal signature initiative at CIHR and showcase how this initiative has facilitated evidence-informed policymaking in Canada.
Thank you, Megan. My name again is Jennifer Campbell, and I'm a senior here at CIHR, working on the CIHR Evidence-Informed Healthcare Renewal Initiative. And I'm pleased to be here today to share with you information about this initiative, which is one of 8 roadmap signatures aimed at supporting research in the area of financing and funding and governance and sustainability of Canada's healthcare system. This particular initiative is unique in that it adopted an integrated knowledge translation approach that is building on the policy and decision maker priorities right from the outset, and those policy and decision makers continue to work with the researchers collaboratively throughout the project's life cycle. So again, the objectives of the EIHR initiative were to fund timely and policy-relevant research on healthcare renewal in Canada, to ensure translation of the research evidence to government officials in a timely way, and overall to increase the capacity of the research community to conduct research in the areas of financing, funding, governance, and sustainability of the healthcare system. This initiative overall was designed to inform the negotiations related to the renewal of the 2004 Health Accord, which was to have taken place in 2014. So there's a number of accomplishments of the EIHR initiative in relation to capacity building, developing collaborations and partnerships, and the development of an EIHR portal that I'll describe in a little bit. And first of all, I wanted to comment on the capacity building element of the initiative, where we did fund a number of expedited knowledge syntheses and a unique program called Healthcare Renewal Policy Analyses that again involve the decision maker priorities from the outset and throughout the research. The Healthcare Renewal Policy Analysis Initiative, as an example, pulled together researchers to bring evidence-informed policy options to policymakers on a particular topic. And one of the requirements of the funding opportunity was to hold a roundtable, a policy roundtable, to discuss the evidence and the policy options to arrive at the most appropriate option for the decision makers. We ensured that the timelines for these funding opportunities were as quick as possible in order to provide the evidence to the decision makers in a timely way. This initiative was unique also in that it involved international linkages, for example, with the European Observatory, to support research in the area of chronic disease and other aspects of healthcare renewal. One of the main outcomes of the EIHR initiative and collaborations with stakeholders, CIHR stakeholders across Canada, was the creation of the Evidence-Informed Healthcare Renewal Portal. So the vision that was defined for the EIHR portal was to be the premier site for linking policymakers and other stakeholders with information on healthcare system renewal and transformation in Canada, and that it become a reliable go-to tool for stakeholders to access evidence. So it has indeed become Canada's most comprehensive free access point for policy-relevant documents in Canada. The documents that are included in the portal, and there are over 1,000 to date, include Canadian jurisdictional reviews, toolkits, guidance, citizen and patient input, stakeholder position papers, Canadian government strategic plans for the health sector, videos and podcasts, and other series. The documents can be searched in this database, which is housed within the McMaster University's Health Systems Evidence site. And so a couple of examples of how decision makers might use the Evidence-Informed Healthcare Renewal Portal. So a ministerial task force might urgently need information about public opinion or stakeholder positions regarding timely access to care. And so they would search in the EIHR portal for such information. Another scenario might be that a regional health authority would be seeking frameworks or toolkits about suicide prevention in Aboriginal communities. Again, they might visit the EIHR portal for evidence existing on this topic. And the third scenario, a graduate student might need to identify key policy relevant documents about recent intergovernmental health accords. The EIHR portal is unique in that it contains gray literature as opposed to published literature that you might find in PubMed or elsewhere. And it's contributed to by a number of organizations, including the ministries, provincial, territorial, and federal organizations, where they're contributing the documents themselves. And so it's become a robust resource for researchers, policymakers, and other stakeholders in Canada. And here you'll see a quote from one of the former deputy ministers of Nova Scotia Department of Health and Wellness, speaking to the value add of the EIHR portal for policymakers in Canada.
Thank you, Jennifer, for the presentation, for showing some of the successes and outcomes of the EIHR Signature Initiative, and for showing us the use and value of having a one-stop shop like the EIHR portal. At this time, I'd like to turn it over to Diane Forbes for her presentation on the Drug Safety and Effectiveness Network here at CIHR.
Thank you very much, Megan. It's my pleasure to provide some information on the Drug Safety and Effectiveness Network, shortened to DSEN. And so I'm going to start with a bit of a background on the program itself. CIHR was established in 2009 in partnership with Health Canada in order to address gaps in evidence that exist between products as they're developed and brought to the marketplace and their application and use in the marketplace once they're actually in use by Canadians. So DSEN was established in order to fill a policy gap. And the situation before the establishment of DSEN was that there was ad hoc research underway in this area, certainly recognizing that the real world experience with pharmaceutical products is terribly important, but there was no mandated organization to undertake research in this area. So DSEN was established to increase evidence on drug safety and effectiveness available to regulators, policymakers, healthcare providers, and patients, as well as to increase the capacity within Canada to undertake high-quality post-market research in this area. And the government committed $32 million over 5 years to establish DSEN and has continued to fund $10 million per year ongoing into the DSEN program. The new evidence generated via DSEN provides decision makers with an important source of information about drug products, safety, risks relative to their therapeutic benefits, and DSEN also provides evidence to support decision making on public reimbursement and the safe and optimal prescribing and use of drugs within Canada. So just to speak a little more specifically about DSEN's scope, the DSEN program is highly targeted. It attends to gaps in information on the safety and effectiveness of prescription drugs, which includes biologics and pharmaceuticals, which are used in the real world. And DSEN targets these particular gaps in information by addressing queries. So a query is a focused and well-defined question which is identified by a healthcare decision maker as being a gap in their knowledge base relative to prescription drugs on the Canadian market. And particularly, a DSEN query is a question that can be answered through DSEN-sponsored research and that could result in increased knowledge in ensuring the ongoing safety and effectiveness of those medicines' use when applied in the real-world environment. So DSEN operates on an integrated knowledge translation model, particularly where our research approaches engage knowledge users as partners in a collaborative manner to see that the actions, solutions, and impacts are focused to provide research findings relevant to and useful to the end users. So the scheme on the right-hand side really describes the DSEN program at a high level. You can see that the DSEN Coordinating Office, which is located at the Canadian Institutes of Health Research, operates as the hub of an ongoing wheel of information generation and communication. Questions are developed by our stakeholders in the regulatory arms of Health Canada, in the federal, provincial, and territorial drug plans, and that are generated by other stakeholders. And again, these are gaps that they're needing filled to really help to make decisions in their day-to-day work. The information needs are identified to us, the DSEN Coordinating Office, as a query, and those are dealt with through two sets of processes, through a Science Advisory Committee and our DSEN Steering Committee to be identified and put on our research agenda. Once identified on the research agenda, our research is undertaken by funded researchers working at academic institutions across Canada, and when that research is completed, the translation of new evidence is then returned back to the party that asked the question. So in a little more detail, the process overview, again, is that decision makers are identifying the research question. Coordinating Office facilitates communication amongst the research network between our researchers and our decision makers to help to determine the feasibility and the capacity to undertake those research activities. For DSEN, capacity includes knowledgeable and skillful researchers, access to data, and innovative methodologies which enable the address of particular queries coming forward. So together, our network members work to assess the feasibility and refine potential research approaches to address questions coming forward. And as we identify those feasible projects, then the research agenda can be formed and the priorities determined by our steering committee. Again, we have sort of two aspects to our main focus of activity: comparative effectiveness research and safety research. And so we need to be keeping a balance between the level of investment and undertaking in both those two research components, as well as in the capacity development mandate that DSEN has. So again, with our priority research agenda identified, then the research is undertaken by the independent researchers funded through the DCEN program, through their research teams. And then we at the coordinating office work to facilitate knowledge transfer back to policymakers and other stakeholders. So in order to make sure that we are able to function as an efficient KT engine, we have established some requirements for our DCEN funded teams, which relates to timely response to submitters of queries, particularly because the information requests coming forward from decision makers need to inform their real work. We need to have clear understandings of the length of time that research projects are going to take and expected due dates for outcomes so that decisions can be taken upon the evidence that is generated. Dissemination of DCEN research results is a very important component for us. So that's both to the query submitter, but also more widely to make sure that there's even broader use and application of DCEN funded research. We expect all our teams to meet the policy on access to ensure that publications are freely accessible online within 12 months of publication. So it's known as CIHR's open access policy. And our nominated principal investigators are to report research findings at the conclusion of projects and at other interim points as requested by the DCEN coordinating office. Again, you can imagine that in practical day-to-day activities, the timelines may change, things may become more critical, there may be changes in evidence needs, so not so much changing the research question itself, but certainly at certain points we may need to have updates at points that we were not originally anticipating in the sort of timelines established. So we also have a number of KT principles, so not so much regulations, but good practices that help to make sure that the DCEN network functions efficiently. So again, the primary audience for knowledge translation is the query submitter. The query submitter requires results, often final and interim, in advance of publication. And we are very conscientious to maintain the fact that the intellectual property of research conducted under DCEN does belong to the research community that conducted that research, and that they do have interest to put that into publication. But our query submitters are very capable of dealing with information to protect its confidentiality in advance of publication, and so really working to close the information gap as quickly as possible is an important principle for our program. Our program does not make recommendations, and KT products that are produced in relation to DCEN projects should not prescribe actions by decision makers. This is a particularly important point if we think of the idea that Health Canada in its regulatory function or province in terms of setting what drugs it's going to pay for under the publicly funded drug plan needs to make decisions bringing together many lines of evidence. The DCEN program is providing a single line of evidence into that. And so DCEN research is presented in a fashion to make sure that there's clarity to the findings, but that there's not recommendations about how that decision should be incorporated, because it's not, the research result is not necessarily a fulsome picture of all the considerations that need to be taken by the decision maker. DCEN KT products, based on evidence developed though, however, may identify options for healthcare providers or consumers. For example, it might be useful for physicians to understand a dose response. So, you know, is the potential therapeutic benefit linearly related to an increasing dose, or do they get a smaller or increasing type of reaction to a change in dose? That's very useful information for us to be able to provide to a broader stakeholder audience. I already spoke to the researchers' intellectual property being safeguarded through the confidential sharing within the network until such time as they have the opportunity to publish their results. And principally, there should be no surprises for the query submitters about the results that are undertaken within the research network. So if we sort of consider Megan's earlier comments in terms of the integrated knowledge translation activities, and look at an integrated knowledge translation checklist, DSEN really fits quite well in the integrated knowledge translation mode, where researchers should demonstrate that the project has been shaped by the participating knowledge user and responds to their knowledge needs. We consider the 4 factors for developing a DSEN research project: the research question, the research approach, the feasibility, and the expected outcomes are all worked and discussed with the knowledge user, and the researchers are working to target their research projects as closely as possible to meet that specific question that's coming forward. So by design, DSEN does meet the IKT principles, but it's not necessarily that simple. In terms of network-wide coordination, we have to take a lot of effort to address the broader audience for dissemination activities, and so we do quite a lot of effort in this area as well, and we're creating guidance documents which will be available on CIHR's website to further communicate how integrated knowledge translation and broader knowledge translation, end of grant knowledge translation, can be facilitated in the DSEN context.
Thank you, Diane, for your presentation on DSEN and for showing us how your team has engaged with policymakers to make research evidence available on high priority topics through this rapid response tool. It is at this time I'm going to highlight several knowledge translation programs at CIHR and how they have facilitated evidence-informed policymaking. For today's webcast, we will focus on 5 CIHR KT programs: Best Brains Exchanges, Knowledge Synthesis, Knowledge to Action, Partnerships for Health System Improvement, or we like to call Fizzy, and Science Policy Fellowships. Each of these programs has immediate outcomes, intermediate outcomes, and long-term outcomes as shown on the screen. In the 2013 evaluation of CIHR's KT programs, it showed that in health practice, including health products, services, and systems, a generally accepted desire exists for products and service provision to be informed by valid and reliable evidence. There is, however, an abundance of evidence indicating that health practice often lags behind knowledge and best practices established through health research. Through the KT programs, we attempt to address this issue and move research evidence into application. The first program that I will look at here is Best Brains Exchanges. Best Brains Exchanges, or BBEs, are part of the Evidence on Tap initiative. The objective of Evidence on Tap is to produce high-quality, timely, and accessible evidence that is of immediate interest in use to provincial, territorial, and federal decision makers. The rationale for the program is really quite simple. CIHR found that there's a demand from federal, provincial, and territorial, and regional health officials for accessible and timely, user-friendly evidence to help support and inform their decision-making. Decision makers tend to need evidence faster than traditional funding approaches allow, and by hosting one-day workshops or meetings that we call BBEs, they bring together best brains exchanges on research, or they bring together best brains, on research and decision-making on government-identified high-priority issues that we attempt to bridge the gap between the two worlds of policy and research. Topics for this program vary very widely. There's transforming community care, BBEs, to pharmacy professional services, all the way through to looking at approaches to slowing the growth of healthcare expenditures. Now you may ask, why do BBEs facilitate evidence-informed policy making? Well, Best Brains Exchanges could be considered deliberative dialogues that are meant to inform policy. Sandy Campbell, who's an independent consultant on knowledge translation, developed an online training module at CIHR directly on deliberative priority set. In her module, she defines deliberative dialogue as a process of collective and procedural discussions where an inclusive and representative set of stakeholders consider facts from multiple perspectives, converse with one another to think critically about options, and through reasoned argument, refine and enlarge their perspectives, opinions, and understandings. The Canadian Foundation for Healthcare Improvement says, a deliberative dialogue creates joint meaning and shared understanding and is a unique and effective problem-solving tool. Unlike any other mechanism, a deliberative dialogue adds both scientific and social credibility to the decision-making process as it unites and empowers those who will be affected by the eventual decision. It should be noted that a deliberative dialogue is not intended to solve problems, but rather it's to create open discussion on the nature of the problem itself. And this is what best brains exchanges do. Evidence suggests that after looking at 24 studies and that we're asking over 2,000 policymakers what facilitated or prevented their use of research evidence, the #1 facilitators of research use was the personal contact between researchers and policymakers. And the #1 barrier to research use was the absence of personal contact between researchers and policymakers. I'd encourage you to look at the website on the slide for more information on Sandy's presentation and learning module. Now on this slide, here's a quote from Laird Rowe. He's an executive director within the Science Policy Directorate at Health Canada and is highlighting the success of the Best Brains Exchange program. Within his quote, he says, the Best Brains Exchange program is seen as a creative and effective way of engaging with researchers, stakeholders, and policymakers to discuss key issues and to bring and build these essential bridges between science, research, and policy. The next program that I'm going to discuss is the Knowledge Synthesis Program. This is another funding mechanism at CIHR. The objective of knowledge synthesis is to increase the uptake and application of synthesized knowledge by decision-making by supporting partnerships between researchers and knowledge users to produce scoping reviews and syntheses that respond to the information needs of knowledge users in all areas of health. CIHR defines synthesis as the contextualization and integration of research findings of individual research studies within a larger body of knowledge on the topic. A synthesis must be reproducible and transparent in its methods using qualitative and quantitative methods. According to Jeremy Grimshaw from the Ottawa Hospital Research Institute, most syntheses are conducted either for the purpose of knowledge support or for decision making. Syntheses for knowledge support are confined to summarizing the evidence around a specific question or issue and do not undertake additional tasks to support a decision in a particular context, whereas syntheses for decision support will commonly include some or all of the following steps. Engagement of decision-making audience in the development of the research question and synthesis protocol, consideration of several related questions using appropriate methods, deliberative process of engaging the decision-making audience to interpret and contextualize the results of the synthesis, and development of context-specific recommendations. Knowledge syntheses are important for establishing the key messages for the global evidence in a research field prior to knowledge translation and to inform the design and conduct of new research. It is critical that information is produced and conveyed in a timely manner to important end users, such as the patient's care and resources may be optimally managed. It is at this time I'd like to introduce Mike Wilson from McMaster University to highlight some of the mechanisms that he and his colleagues have developed that have been proven successful. Mike and many of his colleagues at McMaster have been successful through CIHR's KT funding opportunities. Mike, I'll hand it over to you.
Thank you. So I'm going to be sharing a few examples that we've been involved with for policy-focused knowledge translation. And these examples listed on this slide are primarily aimed at making sure that policymakers have timely access to research evidence and also to support their interactions with researchers to ensure that the evidence is as relevant as possible. So what I'm going to be primarily speaking about is evidence briefs and stakeholder dialogues, as well as citizen briefs and citizen panels, which is outlined in the first point, and then rapid response units. In addition to those, we also provide a one-stop shop, which was referred to earlier, called Health Systems Evidence, which also houses the EIHR portal. So Health Systems Evidence provides all of the systematic reviews in the world related to health system governance, financial, and delivery arrangements. It provides a one-stop shop for systematic reviews about health systems, and then also about capacity building to use them. So we're going to be touching on capacity building in a little while, but I just thought I would flag that one of our new initiatives is an online course called Health System Learning, which is focused on helping policymakers to find and use research evidence. For evidence briefs and dialogues, a rationale are that evidence briefs take a high priority policy issue as the starting point, and in doing that, we then identify the full range of research evidence that's relevant to the various features of that issue. And in particular, we mobilize it in relation to the policy problem, options to address the problem, and implementation considerations. And the evidence briefs draw on systematic reviews as well as local data and research evidence, and overall aim to level the playing field for stakeholder dialogue. And what we mean by a stakeholder dialogue in the next point is that it allows the research evidence to be brought together with the views, experiences, and tacit knowledge of those who will be involved in or affected by future decisions about that high priority issue. And that those stakeholder dialogues allow for interactions between policymakers and researchers to deliberate about the problem, options, and implementation considerations, as well as who can do what next. On this slide, I've listed a number of different features of evidence briefs that we produce at the McMaster Health Forum. First is that they describe the context of the issue that's being explored, and then it mobilizes the research evidence to describe the problem, present 3 options to address it, and identify any implementation considerations in relation to those options. In the briefs, we also use what we call a graded entry format, where we provide 1 page of key messages, which is followed by usually a 12 to 15 page more detailed report that presents the research evidence. And that report is based on findings from syntheses, and we use a systematic approach to be able to identify those syntheses. In the briefs, we also don't provide recommendations for the purpose of that if we did, we would be preempting the deliberations that would take place in the stakeholder dialogue that the brief is informed to, or designed to inform. We also include a reference list of everything we include in the brief. We put it through a merit review with at least 1 policymaker, 1 researcher, and 1 stakeholder. We can take into account equity considerations, and we consider the methodological quality of systematic reviews as well as their local applicability. For stakeholder dialogues, they address the priority issue and convene the usually 18 to 22 stakeholders, which include people like researchers, policymakers, and other health system leaders to deliberate about the features of the problem, discuss options to address it, and implementation considerations, as well as a deliberation about who can do what next, or what are the logical next steps that different key players can take. And those dialogues are informed by the evidence brief, but also informed by the discussion of all the different factors based on the stakeholders' experiences that are around the table. And we convene those that are involved and affected by the issue, and in doing so, we aim for fair representation of people around the table. And to run the day, we engage a skilled facilitator, and we also follow the Chatham House rule, which means that whatever is shared within the, whatever is said within the room, people are free to share, but they're not able to attribute that information to any specific individual. And what this allows for is for people to be able to speak very freely and frankly during the day without fear of having that information attributed back to them following the dialogue. And within the dialogue, we don't aim for consensus, because we find that it's often hard for individuals to be able to commit their organizations to anything, to any specific actions without going back and consulting with others within their organization. So for citizen briefs and panels, the structure and process is very similar, but they play the same role as evidence briefs for citizen panels, but the emphasis is on producing consumer-friendly communication. And the panels themselves provide an opportunity for citizens to share their views and experiences about a high priority issue. And sometimes these citizen panels can inform a stakeholder dialogue or follow up on an issue addressed in a stakeholder dialogue. And what we have found is that they can help to uncover unique understandings of an issue from citizens' perspectives, help to spark insights about viable solutions that are aligned with citizens' values and preferences, identify context-specific implementation considerations, and really help to facilitate and trigger action by getting citizens' views heard. So the features are very much the same in citizen briefs as for evidence briefs, and the only difference is that for our merit review, we also include a review by a citizen, and then we also identify questions for discussion for the panel, and the briefs are written in plain language as opposed to slightly more technical language in the evidence brief. And similar for the citizen panel, very similar to the stakeholder dialogue, with the key features being that they convene those that are affected, not those that are involved in decisions, and it allows for an open and frank discussion while preserving anonymity, and it's designed to help find common ground and differences among those on the panel. So the last example I want to share is about rapid response units. So the rationale is that policymakers work in a world where they need timely access to research evidence to support evidence-informed policymaking. And to do that, they might need some help with finding and synthesizing research evidence given a number of different competing demands, but also when the timeline is too short for them for us to be able to prepare an evidence brief and convene a stakeholder dialogue. So in other words, we think that rapid response units help to fill a gap between self-serve approaches, which would be things like one-stop shops for research evidence, where a policymaker can go and find the systematic review on their own, and full-serve approaches like stakeholder dialogues that are informed by evidence briefs. So in general, rapid response units are designed to provide access to optimally packaged and context-relevant and high-quality research evidence to policymakers over short periods of time. And then what we're able to deliver through our rapid response program really depends on the timeline we're provided. We provide our knowledge users with syntheses in 3, 10, or 30 business days. And what that generally entails is a requester submitting a question to us. And then we help them refine it into a researchable question. We use that question to develop and then conduct searches for relevant literature. We review the search results with a focus on identifying systematic reviews first, and then identifying primary research in a targeted way when no systematic reviews are available, and then synthesizing that evidence in a relatively brief and succinct rapid synthesis, and then sending it back to the requester within the timeline that was specified.
Thank you, Mike, for your presentation, and it's very interesting to hear the work that you and your team are doing at McMaster to help facilitate evidence-informed policymaking. So now we're going to move on to the Knowledge to Action program here at CIHR. This is a program that is a part of the suite of KT funding opportunities as well, with the objective of being able to accelerate the translation of knowledge by linking researchers and knowledge users to move knowledge into action and increase the understanding of knowledge applications through this process. Through CIHR's evaluation of its KT programs, including Knowledge to Action, it has shown that meaningful partnerships are critical to the success of facilitating evidence-informed policymaking. The two quotes on this slide illustrate that from past Knowledge to Action researchers and knowledge users. The meaning of meaningful partnerships is as follows. Researchers and knowledge users describe building meaningful collaboration as key to research project successes and impact. However, the term meaningful is quite nuanced and contextually bound. Meaningful partnerships are characterized by mutual learning, mutual respect, mutually agreed upon roles and responsibilities, mutual recognition of efforts, and mutual exchange of information. Being mutual does not necessarily denote that partners give and receive equally, but that all parties play a role in negotiating roles and expectations. In many cases, researchers and knowledge users have different understandings of their roles and responsibilities required from each team member in order to make collaboration meaningful. Oftentimes, meaningful partnerships are negotiated based on many factors, including, but certainly not limited to, resources, external commitments, technical skills, and many others. The next program we're going to look at is the Partnerships for Health System Improvement Program, or Fizzy. Fizzy offers Canada's health system decision makers evidence-based answers to the most pressing questions. This is a funding opportunity founded on partnerships where every Fizzy project requires collaboration between a decision maker and researcher interested in working together to address health system challenges. Any applied health services and policy research topic can be addressed so long as it responds to the information needs of the participating decision makers. In the case of Fizzy, the decision maker is a knowledge user who has the authority to influence or make decisions about health policy or the delivery of health services. In the Fizzy competition funding opportunity, a decision maker is typically a health system manager, policy maker, or clinician leader, capable of making significant changes to policy or practice. A critical component of Fizzy is to unite policymakers and researchers and to inform research agendas by bringing the evidence needs of policymakers to light. Like knowledge to action, a critical component of Fizzy is partnerships and meaningful engagement. By engaging in partnerships, decision makers and researchers can benefit from the expertise each of them offer and to participate in research that is of high potential for impact and to move high-quality, locally adaptive evidence into practice. The Participatory Research at McGill team denotes that in order to identify and recruit research partners, we need to consider various factors, including assessing the environment around you. An immediate distinction must be made between the potential knowledge users of the research results at large and the integrated knowledge users who will become partners for the specific research project. As you can see on this slide, the study partnership is situated within the larger environment of knowledge users, which are all of those who might benefit from or be impacted by the results of the research, but not necessarily involved in the production of it. Integrated knowledge users are those knowledge users who are actively involved in the knowledge production process of the given study or project. Note that within this diagram, it situates the academic partners as a subset wholly within the realm of knowledge users. Additionally, the following questions should be considered when deciding upon whether or not knowledge users should fit your project. Is the research topic important to the knowledge user? And does it reflect the reality of the needs on the ground? Is the knowledge user knowledgeable about the research context, its cultural norms of practice and mechanisms of knowledge creation and diffusion? Is the knowledge user well respected within the research context? Is the possibility for congruence of plans? Is the potential for a truly synergistic relationship to be developed? Is it potential? And does the knowledge user have the capacity, for example, human resources, technical skills, or budget, to engage in an effective and active partnership? I'd encourage you to visit the website on the screen for more information on the guide for how to develop researcher and knowledge user collaboration in health research. And the last program that I'm going to speak to is the Science Policy Fellowships program here at CIHR. The objective of the program is to provide high qualified candidates at the postdoctoral, doctoral, and new investigator and mid-senior and investigator stages of health research with the opportunity to learn more about current health policy activities and science policy interface. More specifically, this program aims to build capacity by establishing and nurturing critical links and collaborations between policymakers and health research trainees and investigators in addressing health challenges, and it's to help inform best practices for promoting the exchange and uptake of information between policymakers and health research. The program also encourages trainees and investigators to conduct policy-relevant research that addresses challenges that are facing society now. It also encourages science policy integration through knowledge translation. It is at this time I'd like to introduce Dan McLean, who was funded as a Science Policy Fellow and through this program just recently. He is now a policy analyst, as mentioned earlier, with Health Canada. Dan, it's over to you.
Thank you very much for the introduction and the opportunity to talk about my public policy journey. As someone who has generated knowledge and is now a translator, consumer of knowledge, it is always a pleasure to come to forums such as this. I've given this talk a few times in different contexts, and the goal is generally to highlight the lessons I learned as I transitioned from academia to public policy, with the hope that there might be some broader themes relevant to knowledge translation in general. So I was given a Science Policy Fellowship in the fall of 2012 and joined the Strategic Policy Branch at Health Canada in the Office of Pharmaceuticals Management Strategies. The key feature of Science Policy Fellowships is that they require the fellow to relocate and be embedded in a policy shop. It provides an opportunity to build relationships and experience policy firsthand, which is a critical element in a bureaucracy. The Office of Pharmaceuticals Management Strategies aims to facilitate the successful adoption of technology by the healthcare system in a sustainable way that improves the health of Canadians. To give you a bit of a context in which I came into the public service, I want to highlight my formal training. I completed a PhD at the University of Toronto in Professor Molly Choyket's Regenerative Medicine Lab, where I developed novel antibody-based contrast agents. Molly's lab is an interdisciplinary lab composed of biomedical engineers, stem cell biologists, and chemists. So that is the lens through which I viewed the world when I landed at Health Canada. The project I was given to work on was to investigate the prices of non-drug health technologies, such as medical devices or hospital procedures, in Canada and abroad. Very little is known about the prices of non-drug technologies, despite the high expenditure. These technologies are often patented, which distorts the market, and there is a federal role in Canada for intervention. Without knowing the prices, though, it is difficult to judge whether this power should be exercised. You'll probably note that there is very little about my background that prepared me for this project. This is an important lesson that I learned very quickly in the public service, which is fast-paced. What you worked on yesterday is really relevant for what you'll work on today. It is the core skills of a public policy analyst that are useful: writing, analytical thinking, creativity, communication, and research. The rest of my talk will highlight sort of 3 lessons I learned over my fellowship. First, it's all about the top line. Especially in a strategic policy shop, issues are often at 30,000 feet. One could drill down on analysis to a virtually infinite degree. One has to get a sense quickly of when the analysis you've done is enough for the decision that needs to be made. To illustrate this, I've copied in a briefing note that I wrote during my policy fellowship. A briefing note is the policy analyst's core tool. These notes have a summary box, which is permitted to contain between 3 and 5 bullets, no more. One always runs the risk that a decision will be made based solely on what appears in this box for a variety of reasons. What I would always remind myself, and what I continue to remind myself is, or to ask myself, is when the analysis that I'm continuing to do no longer changes what is in that box. If it no longer changes what's in that box, then further analysis is probably not useful. Second, nurturing a fast absorption rate. In a policy shop, every day can be a new day. Issues frequently come out of left field, so to speak, and one must be prepared to quickly pick up new subjects. During my time in strategic policy, the Canada-EU trade agreement was signed in principle. It was a strange experience to be called into a boardroom and have work plans completely thrown out the window and receive entirely new analysis based on changed priorities. This isn't something that happens in academia very often. Being able to pick up new subjects and provide new analysis on short time frames is critical. Third, important versus interesting. This is a concept I think all policymakers struggle with. It is easy to chase interesting ideas and go down a variety of rabbit holes. But at the end of the day, interesting isn't nearly as influential as important in the public service. It requires constant awareness of what is important to decision makers to keep from getting distracted. During my policy fellowship, one of the most novel or publishable parts of the work that I did was on physician fee codes. This wasn't particularly useful to Health Canada because it is outside of our jurisdiction and subsequently received almost no traction, despite it being one of the more novel things that I did during my time. Which serves as a reminder that if it's not important, it will probably be ignored and you won't be influential. In summary, I want to highlight what I think are the contributions that can be made inside and outside of government coming from an academic background. Working in government The public service is well served by thoughtful, rigorous, and creative analysts. All of these skills are developed in academia. Outside of government, the Government of Canada likes to describe itself as its policy making as evidence-based. We rely on experts like yourselves to inform our decision making. To be effective, though, the advice needs to utilize brevity and focus on what is important to the decision maker. So in conclusion, thank you for your time and for letting me share my science policy fellowship experience and the hard work that all of you do generating and translating knowledge. The Canadian public policy environment is stronger because of this, and Canadians are healthier and safer as a result.
Thanks so much, Dan. Your presentation truly highlights how important capacity building is in this complex research and policymaking environment. So now we're going to get ready to end off our presentation by looking at what all this information means and as you move forward with your research, and to highlight a few overarching principles that we've seen throughout this presentation today. As shown throughout this webcast, there is definitely a benefit to having evidence-informed policymaking. Adding on to this, the literature has suggested that the following benefits related to the incorporation of KT into research projects, all in which assisting in the closing of the no-do gap, are important, and they further reinforce the need for this type of research and work. Evidence-informed policymaking can assist in further understanding of the decision-making. It can enhance the research process, increase trust and mutual understanding between policymakers and researchers, establish long-term knowledge and understanding of a problem or issue, have increased enhanced relevance to a research project and research outcomes, and have access to resources and data in which you may not have access to before. But we certainly have to ask, why is moving research and knowledge into practice so hard? Here are a few things to consider whenever you're thinking about moving research to action. Think about relationship building issues, the lack of skills that a potential knowledge user may have, or other research as well. Time commitments and constraints can often hinder a project, and resource commitments as well need to be set up front. There are a number of important lessons related to successful knowledge translation, including both end-of-grant and integrated approaches, and they've emerged directly, and they're directly relevant to facilitating evidence-informed policymaking, whether you're a researcher, manager, practitioner, or policy developer, that I would like to mention here. They include: try to involve evidence or end users in your projects. For certain types of research, the people who will use the research results should be involved throughout the research process, starting with helping to identify the problem and refining the research question. This participation of knowledge users helps to ensure the research responds to an identified need, and also increases the chances that findings will influence the programs and policies over which the knowledge users have influence. This two-way exchange of knowledge can likewise have a direct impact on researchers. You should also consider all potential stakeholders. The focus of knowledge translation can and should be directed to all stakeholder audiences. You should customize your message and clearly focus the message on specific audiences of the research findings, and crafting the messaging so that it has resonance and will be critical to them. You should help end users overcome usage obstacles by considering the barriers that may prevent specific audiences from using research knowledge, and then selecting and tailoring knowledge translation strategies accordingly so that they can improve research use, and communicate the benefits of KT. There is a clear need and importance for evaluating the impact of KT so that it can help potential knowledge users better appreciate the importance of and need for doing knowledge translation. So after hearing all this, we need to ask, why have evidence-informed policymaking? So I will let the evidence speak for itself. In 2003, Landry & Company surveyed 833 Canadian officials from government agencies about what determines the use of university research in government agencies. One factor was the intensity of links between policymakers and researchers. Another was the background of research user in their acquisition efforts. In another study conducted by Gabi and LeMay in 2004 called Ethnographic Mind Line Study, they found that clinical guidelines were translated into practice through social interaction and interpersonal networks. Meanwhile, in another study, it was found that knowledge depends on its circulation networks and will only diffuse if these social features are taken into account and barriers are overcome. From this evidence, it is fair to say that there is a need for evidence-informed policymaking in moving research knowledge into action. Despite evidence-informed policymaking being a rather complex beast with many factors to consider and battle, I do hope that this webcast was both informative and convincing as to why evidence-informed policymaking is in fact important. Through this webcast, by highlighting several unique programs and knowledge translation approaches and tools that CIHR has developed, it is clear that there are many options available to conduct evidence-informed policymaking. However, the underlying principles remain the same throughout these programs and all the initiatives that were showcased today. For further information on CIHR's online resource and some of the information that was shared today on this presentation, I encourage you to visit the online resources pages at CIHR's website. Here you will find the online learning modules that were described in some of the slides today. In addition to this, we have several KT resources that are available for researchers who are looking to apply to grants, and this includes some KT casebooks as well as guides on how to write letters of support. I'd also strongly encourage you to visit CIHR's webpage. It's listed at the bottom of this slide, where all of Ian Graham's chapters from his book on knowledge translation in healthcare can be found as presentations on the CIHR website, as well as visit the KT Clearinghouse website. On this slide, you'll also find additional resources that are linked to Mike Wilson's talk that are based out of the McMaster University. Thank you very much.
Well, thank you so much, Megan, for coordinating such an interesting presentation on the KT initiatives and informing policy at CIHR. I also want to thank everyone for participating in today's webcast. We hope that you found today's session to be very informative, and as a reminder, the webcast will be archived on the KTDRR's website at www.ktdrr.org. We also have a brief online evaluation form and would appreciate your input about the webcast. The link is on the last page of the presentation file, and everyone who registered will also get email with a link to the evaluation form. Once again, a big thank you from the staff at the Center on KTDRR to our presenters, Megan Baker, Jennifer Campbell, Diane Forbes, Michael Wilson, and Daniel McLean. We also appreciate the support from NIDR to carry out the webcast and other center activities. On this final note, I will conclude today's webcast and invite you to participate in the others from this series.